very, very much appreciated. We've learnt a lot from the process. And the idea here is that, I'll just tell you where it came from and why I had the idea in the first place. Rick will then tell you how the project ran, and then at the end of that we'll have some dinner. We've hopefully got some nice food. Let's see what arrives. What we want you to do whilst you're having your lunch is have a quick chat amongst yourselves about what you think about what we've told you today. And then we'll just get a little bit of feedback from you, because we want to take this project forward and run it on a bigger scale and do it slightly differently. But your input would be really sort of valuable at this stage. So that's kind of what we'd like to do now. So you're not getting a free lunch. You have to work just a little bit for us. I keep quite your stomach in because this is being recorded and the DVD is going off to all the medical practices so the doctors can see, because I don't think any of them could make it today, but we'd like them to see how this project went as well. So that's why this is all being recorded. I hope the editing is quite clever. Right. Put somebody else's face on mine. So this project started the idea came in 2006, and I was asked by the professional body to look at how pharmacists were trained compared to how doctors, opticians and dentists were trained. So I actually visited medical schools, dental schools. I actually went to some other schools of pharmacy across the world. And what became very clear to me in the difference between the education between pharmacists and all the healthcare professionals, they meet patients really early on. Generally, doctors, dentists, within the second year of their course, are spending a lot of time with patients. Okay? Thank you. So yeah, so it's really obvious to me that doctors, dentists, opticians were seeing patients in year 2. By year 3, they were actually providing services to patients. And I know that from my old university, our School of Optometry had its own clinic on campus. And people, when they wanted their eyes tested, came onto campus, and the patients did the eye the students did the eye tests. And we found that dentists were actually doing, dental students in the second year were doing dental checks. By the third year, they were replacing fillings. And we know medical students at UEA are actually out with patients in the first week of their first term. Pharmacy students, and UEA is probably one of the leading schools in this, we send them out, but they go out for half a day in the first year, or a couple of days in the first year, a couple of days in the second year, but don't really get lots of patient contact. They spend more time actually with other pharmacists than do actually with patients. So I sat there and I thought, well, why is this? What do we need to do to change pharmacy training, and what could we offer to patients that dentists and doctors offer? And I thought, well, actually what we can offer is actually review your medication and talk to you about your medication to help you better understand it. So that's something we could offer, and that's something we could start getting pharmacy students to do much earlier on in the course. So this idea that we had, we applied for funding. Rick and I applied once, we got turned down. We applied again, and it took till 2010, that original idea, for us to finally get the money to run the project. And we looked at our students, we looked at our training, we decided actually our training is very scientific, and so we couldn't send our second year students out like dentists and optometrists do. So we sent our fourth year students out. So that's who you got to meet, that's who ran the clinics with you. And there's a lot of really interesting learning books, because this is the first time we've sat them in a clinic with the real patients themselves to really talk about medicines. And there was a lot of things that came out of that made us think a lot more about our training and how we're going to train pharmacists in the UK. But the way we're going to train pharmacists in the future is very much closer to how we train doctors. So they are going to be seeing patients in year 1 and year 2. They are going to be spending a lot more time out in practice and less time in the laboratory. So this, all part of this research all sort of leads into that, and will have a major national impact as well. So I'm not going to say any more. I'm going to let Rick talk through the project now, how he delivered it and what we've learned, and then we'll have a discussion later.
As I said, the first part of this is to thank you, because in effect what everyone here has done is hopefully helping to move forward pharmacy education for the future, and in doing so the only reason we'd like to train pharmacists is to help patients. So actually what you're doing is hopefully helping patients in the future. And I think it's important to thank all the different people now. We had lots of patients involved, and there are two sorts. And in fact, funnily enough, early on, we learned from the patients that they don't like the terms we use. We talk about intervention and control, and they sat there saying, we don't like that. So really, the intervention group is the patients who met the students and actually received something, and also did the questionnaires and let us look at their results. And the control group is those people who kindly said, yeah, we'll participate, but all we do is fill in the questionnaires, let you look at our results, and nothing else. And those are the ones you generally lose. But they're as important, or some people say more, but because unless you've got someone to compare with, you don't know whether you've actually improved or not. So it was fantastic that we had both sets. So we have to thank all our patients. Within that group, I'll lump patient representatives. And Margaret and Dave, who sadly couldn't be here, we had two people who represented patients on one of our management groups and kept an eye on us and said, why are you doing that? And, oh, that's a good idea, but maybe if you changed it. The students, I still talk about them as my students, and I can't help it because they were fantastic. They volunteered. All this was outside their course. They got no credits for it. It didn't improve their exam results. They spent a lot of their free time doing this work. And without the patients and students, nothing would have happened. The GP practices, they recruited the patients for us, because we're not allowed to look at your records until you've given permission. So they contacted for us. And then also they let us use their premises for their meetings. And in some cases, members of staff came back and came in at the end and joined in and said, yes, here's some feedback, and helped the students along. Had some pharmacists from what was then the PCT, they've changed all the initials now, it's CCG, but it's the local organisation. They help with some of the supervision. Admin, you've met Francis. Lots of people didn't meet Francis at the beginning. All they heard was a voice on the phone. Making appointments. I don't know what I would have done without her. And at the bottom here, there are lots of words, but basically the NIHR, National Institute for Health Research, they funded this. And they fund things like this to say, well, we've got a good idea, and they said, well, go away and research it. Before starting on patients, actually do it properly, research it, and find out if it's worth doing. In fact, the major change we made from that was, originally we thought, we'll bring the patients into the UEA and have a meeting there. But everyone said, no, go to the patient's GP practice, which is what we did. And it was better for the patients because we didn't drag you all the way into the UEA every time. And in fact, I think it was better for the students. Certainly some of them said they appreciated it because it felt more real, and they actually met other healthcare professionals, which is something that they don't during the course. The GP practices then sent out letters for us, recruited patients. We'd already recruited the GP practices. We wanted 4, and in fact we were lucky because another one came along and said, can we join in? Which helped our numbers. We recruited our students, they were on site, we emailed them and said, please come along. And quite enough, we got virtually half the year volunteer. And as I said, we recruited the patients, and then the pharmacists through the local organisation, and most of them I knew anyway, and it didn't put them off. And then, having had patients volunteer, we have to randomise, and it's a bit like tossing a coin, but these days we try to be a bit more technical, so instead of just tossing a coin, the computer tosses a coin for us. And it's a special program that I can't interfere with, so I can't say, I'd really like that patient, they don't look very well, so I want them in that group, and that one looks really well, I'll have them in that group. I have no control over it, and that's very important. And then we set to and train the students, and I'll talk a bit more about this later, what I thought, what we've learned about that, but we had 3 sessions primarily. One where we taught them to access patients' records on the computer of the GP practice. One where we taught a bit more about care planning, which is our term for, they look at your records and say, is there anything we can do? What can we talk to you about? And then consultation skills, which again is a posh term for how do you talk to a patient in an interview. And there are huge amounts written about this because so many people get it wrong, and partly because it's not taught. So, and then we had a role play, a dummy session, which we tried to get as near to real life as we could. We had professional actors as the patients, and we did this in proper consultation rooms, and in fact, I think it was fairly real, because at the end, there was one actor who the students said, she was so scary. But it was more real. And then we took the students out to the GP practices, and they accessed the patient's records. This is the patients who were going to meet a student, so our intervention group, as we call it. And they looked at the records and said, okay, what's there that we can talk to the patient about? One would be very surprised if a student was able to go through the records and find something dramatic clinically that the GP hadn't already dealt with. So we didn't really expect that. And then we got down to the real meat of it. The students met the patient just for one session. So in the end, each student had, well, 1 or 2 students only had one opportunity, but most students had 2 opportunities to meet a patient, to sit down and have a meeting. And as Dave said, this is their first opportunity. This is something we think is a good idea, but we need to find out if it really is, if it works. And then at the end, we went through and we had more what we call focus groups. We said to people who had taken part, what did you think to it? Where did it go wrong? Where did it go right? Because the wrong is as important to find out as the right, because then we won't do it again. We then looked at patient records, and I did lots of analysis and lots of statistics and lots of numbers and lots of figures. And so what did we find? Now it's important to say this is what we call a feasibility or pilot study. So rather than charging on in and doing a huge study and saying, oh, we spent a lot of money, dragged a lot of patients in, dragged a lot of students in, I wish we'd thought of that in the first place. So this is a small study designed to actually show us how to design a bigger study. And very importantly, we found we could recruit people. If you can't recruit people, either what are you doing wrong, or give up, go away and do something else. And it is possible to recruit, so we can go on. Very importantly, few patients left the study. Incredibly small numbers. And that's important for a study, because if you lose half your people, then do you have twice as many people to start with, or is it worth doing? We lost quite a few students. That's our fault. I think some of it was to do with the fact we were asking them to do it in their own time. The pressures were great. They were doing research studies. Some of them found it difficult to get released from their research. There were a number of reasons. And some of it actually was to do with, I think the training could have been better, and the timing. And I'll come on to the timing. We found that in some cases, because of the way the recruitment went, that students had had their training at the beginning, and then there was a long gap, and then they met a patient at the end, and he was, right, hang on a minute now, what did they tell me at the beginning? So what we need is to sort this so that we can have the training, meet a patient, and it's fresh in their heads. as I said, this was a key thing we found that at the beginning we didn't know. It has to be in the GP practice. It's so obvious to you people, but we've learned that. I think we need to liaise better with the GPs. Something we'd hoped was that we'd be able to get a number of GPs available for the students to say, well, we think what we've found is, and what we'd recommend is this for this patient, and then the GP to give feedback. And the GPs are busy people, but maybe if we can find better ways of talking to them, we might be able to get around that hurdle. And actually, we found some positive effects from the students' input. Now, something I'd say is, I'd repeat what I said at the beginning, this is a very small study. And with SAD people, we concentrate on statistics, and we talk about statistical significance. Really, what it means is, have you got enough numbers that it means something? And if you've only got a few people, and you find something happens, does it mean anything? If you employ the whole world, and you find something happens, you can say yes. So we have to work out numbers. So there's an indication that is going to be good. Now, it's a hideous picture. We like these sort of things. But if I just explain, this is the flow chart of the patients, and this is quite important to us. The GP practices invited nearly 800 people for us. And we managed to add to that to recruit 133. Now that's around about 16–17%. Anywhere near 20% is generally accepted to be pretty good. So we were very lucky, and in fact, one practice, for a number of reasons, only managed to recruit about half the level that the other practices did. So really, overall, if they'd been the same level, we could have managed about 20%, which is fantastic. So we were about 84% of what we hoped for, which is pretty good. And then, as I said, we stuck it in the computer, it tossed a coin for us, and we came out with almost equal groups. Now, this is the group that didn't meet a student. And I found that's incredible. We lost 2 of them. One poor person early on passed away, and one person left the area. Those are the only 2 people in that group that we lost. And to us, that is fantastic. The loyalty that showed to us. In the group that met the student here, we lost one straight away. A nurse said, probably on reflection, this person isn't ideal to meet a student. So, okay, we didn't. After the students had been through the records, one lady withdrew because of a family bereavement. 2 patients we withdrew because a student had seen their records, and then she subsequently withdrew. And 2 patients were ill and said, sorry, we can't continue. We respect that. We don't ask anything else. We just say, thank you. And then we invited people to come in. And at the very last hurdle, we lost one person who was too ill to attend. And in fact, 2 people forgot to turn up. Now, again, that's something that we've learned. You know, that's down to us. What I should have done was said, okay, fine, we'll invite you, but at the last minute we'll send you a letter as a reminder. So it's all these little things that we'll learn. But at the end, 58 patients received what we call a medication review. They had a meeting with a student. And with the numbers involved, I think that's fantastic. And it shows that we could manage with a bigger study. Okay, I'm whizzing through, I'm trying to not spend all your time. Did we manage to show anything? Well, you know all these lovely questionnaires you filled in, and you probably sat there thinking, why are they asking all these stupid questions? Well, what we do is we do all sorts of statistics on these, so we number crunch them. And this is just one small part. So this part reflects what people think about the information given to them, or information they need. And the black lines are the patient, is an average score from the patients who met a student, and the lighter line is an average score from those patients who didn't meet a student. And in almost every case, the score from the patients who met students is greater. I cannot explain the last one. The question, will it affect your sex life? And I'm not even going to try and explain it. But a number of these things apply to, for instance, side effects. So, does the drug have a side effect? What are the risks of that side effect? How to manage the side effect? And things like making you drowsy, which is a side effect. And with those things, the patients in the questionnaires reported these questions are asked in such a way it's not always obvious what we're after, because otherwise people will think, I know, I can answer like this. So we got what we think is an impartial indication that the students did help with information about medicines. As I said, the numbers are small, but to us it's a good indication that there's something they can help with. Normally this information improves what we call adherence. In your terms, it's, do I remember to take these tablets I have to take every day? We didn't affect that. But what I would say is, the scores showed that at the beginning, the average was fantastic. Both groups had fantastic memory of taking tablets, and it was the same at the end. So really, there was very little there the students could influence. Although, quite interesting this, we found a very high use of the little boxes. You know, these little, there's lots of different sorts. The little ones where you put the tablets in each day, you know, morning, lunchtime, tea time and evening, to remind you. And maybe that was one of the reasons. And in fact, Debbie, Dr. Bhattacharya, is doing some research in that area at the moment. Well, no, you've actually finished your writing up, aren't you? The enjoyable bit. We also looked at results. So we looked at blood pressure. Well, the blood pressure of both groups before was pretty well what we would hope it would be. And there's very little we could affect. But though for reasons that, again, we can't predict, at the end, the control group, those patients who received nothing, it improved. Can't tell you why. Glucose control is quite high. I'll put both numbers on. You've probably all found it's changed from the old numbers to the new numbers, and you have to try and remember both. So I'll put both on, but they were quite high, but neither group really changed much. And cholesterol was pretty well as it should be, very little they could affect. But this is something important to us. It may not sound much. Sample size calculation. All of this enabled us to do this. What it means is that if you have too few patients, any statistics you calculate don't really mean anything. If you have too many, it means it's cost lots of money, and you drag lots of patients in for no reason. And we've calculated that we need 159 per group, so, okay, 160. So really, double our target. And that's a very important finding for us. What would we change? We got quite a bit of feedback about changing the language in the leaflets. So, getting rid of abbreviations, explaining funny words, or trying to avoid funny words, and having an explanation at the very beginning. If you read nothing else, you just read that. Change the questionnaires a bit, and in fact one section will completely take out. We might change either the type of patient or the time. So, for instance, the timing. If the student met the patient as soon as they were diagnosed, rather than 2 years down the line, which is what we did, there might be a greater need for information. So we think possibly earlier on, or patients who have problems, or a whole variety of things, but we think possibly that's something we need to change. The students might be pleased to hear this. We think what we need to do is, if we repeat this, do it as part of the course. We don't ask for volunteers who give freely of their time. We put it in the course, we timetable it, and they can just turn up on the day, or else, and it will happen. And students like feedback, but we think we need to even get better feedback. I think Dave alluded to this. We think the results show that we can justify doing a larger study, and possibly in conjunction with a couple of other schools of pharmacy, to either definitively prove or disprove what we think. And okay, we'd like to prove it, but that's the whole point of doing research. If you don't know the answer, you do some research.
Hi there, everybody. So firstly, I'd like to say thank you to Rick for inviting me here today. It's always lovely to have an opportunity to come back to Norwich. When I volunteered to take part in the project, I think I was hoping to learn about the treatment of diabetes, but what I was really excited by, but also quite scared about as well, was having the opportunity to talk to patients about their medications. The preparation that we went through as students was really helpful. The opportunity to have this trial run with these actors playing the patients and then receiving feedback on how I'd done was useful preparation for talking to you guys, the real patients in the GP surgeries. It was great to be able to learn about the condition of diabetes, the drugs we use to treat it, and the national guidelines, but then being able to apply that knowledge to the care of a patient. And I think, certainly from my point of view, learning in this way made me remember everything a lot better than just sitting an exam at the end of it. Practicing consultation skills is something which is a lot of in the pharmacy school at UEA, but often it was in the context of a classroom with your course mate pretending to be a patient and reading from a script while you pretended to be the pharmacist. Therefore, the experience of speaking to a real patient in a real setting of a GP surgery was an opportunity that I really valued, and it was really important in my development as a pharmacy student and now as a pharmacist. This experience was, I'd say, an invaluable contribution into making my first real drug history as a pharmacist in a hospital kind of an easier experience. And now going to the end of a patient's bed and talking to them about what medications they take and their knowledge, understanding and concerns with them is just something like a natural thing to do. As pharmacy students, we do spend a lot of time in lecture theatres, which, like Dave said, whilst our trainee doctor colleagues wander around hospitals trying to find patients to examine and talk to. So since being involved in the project, I think to do something like this as part of the pharmacy undergraduate course would be a really great idea. And then in February this year, Health Education England identified the enhancement of the communication and consultation skills of pharmacists as a key priority. With this in mind, I think the incorporation of patient consultation opportunities would help produce pharmacists who come out of university having already begun on a path of being able to deliver patient-centred care. That's it. Thanks very much.
Now, timing as it is has worked out very well. Food has arrived, so let's have some food. As Dave said, there's no such thing as a free lunch. Could we possibly ask you that in the people you're sitting near, and I guess you'd have a chat with people anyway, but over lunch, could you maybe have a chat and just say, if nothing else, do you think we should repeat it? Because we think so, but you might disagree. And was it something particularly good, and was there anything particularly bad? Because there might still be something we've missed.